number of pain specialists that exist in the country compared to the number of pain patients, it's 33,000 to 1. We're not going to win it. And most patients, if treated more comprehensively earlier in their pain cycle, could probably cut off the chronic pain cycle. So step care model for me is a training syllabus, if you will, of how do we work a team together so that we can intervene sooner on patients, but escalate care when needed as well in a fluid, rapid manner, and more importantly, eventually, ultimately bridge them back to self-care and stop their reliance on the healthcare system.
Good pain care is a team sport that requires a coordinated effort across the entire healthcare system to prevent acute pain or simple chronic pain following injury or disease from becoming complex chronic pain with all of its medical and psychosocial consequences. The majority of patients with chronic pain are managed in primary care. Therefore, medical specialists need to work with primary care providers as part of a patient's pain team in order to ensure that the level and intensity of pain education and comprehensive care is provided as early as appropriate in the pain care cycle. The stepped pain care model provides a structure for applying pain care prevention, education, and treatment strategies and capabilities at the appropriate time in the pain care cycle.
And so the step care process at least coordinates effort of care, and they're ready to change because they're already working in a much more coordinated fashion. You're being looked at much more as a whole patient. That's the idea of it. I think the step care process demands that you come up with a program and a plan of how people utilize their assets on behalf of the patient. Here's the most common problems we have. Here's the tools we would need to address them. Now we want to use them in a coordinated fashion at the site that patients are most frequently seen. So the step care process really does that, but involves not just primary care, but involves the entire spectrum of healthcare.
The very first step in pain management involves patient education. This will enable them to adopt effective self-management skills whenever possible, and will be a foundation for their overall pain care plan. First, you want to explain the basic neurophysiologic and behavioral mechanisms of acute pain and how it transitions to chronic pain. This will enable them to understand the limitations of traditional biomedical treatments to cure chronic pain. Next, you want to explain the importance of their active participation with their clinical team in making informed clinical decisions about treatment options that are available and designing a treatment plan that's going to work for them to help their functioning and their quality of life. The foundation of this plan is going to be self-management, learning self-management skills, icing and stretching, yoga, meditation, things that can actually help them get through their day with their chronic pain.
There was a time that I wouldn't have made the connection between my pain management and good nutrition and healthy sleeping habits. They started to educate me that, hey, these things have an effect on my sleep. These things have an effect on my lifestyle. These things have an effect on my pain.
The next level of care is the primary care treatment option that aims to treat acute pain rapidly and effectively in order to avoid progression to a chronic pain condition. When chronic pain exists, this second level of the stepped care model includes a focus first on the use of non-medical options, such as cognitive behavioral therapy, mindfulness, and physical therapy, and consideration of non-opioid medications.
Benefits of the step care model exist in both primary care and in specialty care settings. For instance, in the perioperative arena of care, a step care model will improve the integrity and the continuity of care for patients by tying together the primary care team with the many subspecialty teams needed to operate and ensure the fullest recovery in a patient. In the past, complex patients with pain have gone to the operating room without any coordination between the primary care provider, who knows the patient the best, the outpatient pain provider, and the perioperative surgical and pain team. With a step care model, the entire system can maintain contact, communicate with each other and with the patient, and provide a coordinated approach to care. Such coordination and co-management provides reassurance to both patient and family and an opportunity for feedback amongst clinicians in all settings about how the system is functioning and supporting good pain care for its patients.
One of the really innovative things that VA is doing is called a patient-aligned care team, or a PAC team. And so what this does is it brings together different specialties into the healthcare team so that when a decision is made, not only do all those providers know about what's going on for that patient, but that patient also gets the benefit of the input and the knowledge, the combined knowledge of all those providers to really make an informed decision about his or her care.
Besides benefiting patients, the STEP care model also benefits providers and clinical teams. It does this by creating a learning and feedback system that aims to mentor and educate both our primary care and specialty colleagues to improve their skills and comfort with pain management. We utilize an academic detailing approach, following the ECHO model, with weekly case-based presentations combined with formal standardized didactics from the VA-DoD Joint Pain Education Program, or JPEP. Let's look at how this helps heal the relationship between the subspecialty and primary care specialists, which can be antagonistic, particularly when it involves the often controversial topic of long-term opioid therapy. The conversation will often crumble into a blame game, with the patient being at risk of being treated like a hot potato and unsure of who really is managing his or her care. This, of course, would lead to a situation where both sides differed on the goals of treatment, confusing the patient, family, and the system itself on the care plan. Since sharing cases and education on a weekly basis, phone calls are much more collegial, which leads to more collaborative care, safer outcomes, and provider satisfaction and patient satisfaction.
Maintaining positive and open communication within the entire healthcare team is essential when assisting a patient with pain early on and throughout the course of their pain management. The goal is to manage pain more thoroughly at this primary care level to prevent the onset of chronic pain and its complications, thus escalating to a much more resource-intensive path to achieve optimal function. For some patients, however, a personalized, multidisciplinary, multimodal program is suggested.
So our intensive outpatient program is built on the premise of we have physical therapists, we have a health psychologist, we have a nurse educator and administrator, but the education part is incredibly important. We now have developed a case manager in there, and we have a pain physician.
These teams may consult on many patients, but takes on only a limited number of patients to work with intensively on achieving pain management goals that are focused on functional improvement and quality of life.
When patient treatment and care is coordinated very closely, very well, that really has a huge net positive for the patient. In my own experience, having chronic pain, you had to tie in a lot of different people. There were people who from the physical therapy area, there were people from the pain management side, there were people from the primary care side. There's nurse case managers who are shepherding everything through and kind of triaging a lot of the questions that come up over a multi-year relationship with these providers. So having that coordinated, closely coordinated care really helped and really changed the outcome. No two patients are going to be the same. No two patients' pain is going to be the same. And so when you bring together different specialists, different concepts, different ideas, and the patient and the provider really make an individualized decision, that's going to be where the most benefit comes out.
With the entire healthcare team on board and a focus on more effective and timely treatment of acute pain, fewer patients will be required to unnecessarily progress upwards on the stepped care pyramid. However, if chronic pain continues to escalate, it might be necessary and certainly appropriate to explore options at the next level of the stepped care model, secondary care, which includes specialty and subspecialty care.
In our experience in managing battlefield injuries from recent conflicts, many of our patients who underwent amputation, either traumatic or electively, suffer from residual limb and phantom limb pains. However, they commonly also suffer other conditions, worsening pain and complicating their care, including other nerve injuries, regional or whole body, musculoskeletal pain, psychological injuries such as PTSD and depression, and residual symptoms of traumatic brain injury such as cognitive challenges, hearing loss, and disequilibrium. All too often we view them and assume, oh, your problem is right here in your leg. Not so. They're dealing with various combinations of these injuries. It's hard to separate these elements when considering the somatic and the affective sides of pain, but it's critically important to identify each one and incorporate plans for their coordinated co-management. And so we need to identify and manage conditions such as depression, PTSD, and TBI in any of our patients who have undergone amputation from a blast or other traumatic experience. We also may need to deal with issues such as the appropriate use of opioids. Opioids may be appropriate in the acute phase of pain, but in the long term may involve risks and not be that helpful.
The single most helpful thing for my own recovery and treatment has been an engaged provider. That's something that you can't prescribe.
If chronic pain continues to worsen or is refractory to standard pain medicine specialty care, it may be necessary to advance to the top tier of the stepped care model, which is tertiary care. At the tertiary level, a chronic pain patient could be referred to subspecialties, including personalized gene-based medicine, neurostimulation, neuromodeling, and rehabilitation centers. Once again, it is the primary goal of the stepped care model to address acute pain aggressively in the early stages in order to minimize the number of patients requiring this level of care to achieve optimal function and quality of life.
In our system, we talk about that sometimes it can be as many as 9 different systems that a primary care provider has to tap into to gather the data they need for an individual patient. That's insane, right? It harkens back to the day of we wanted a camera on every person's helmet in war. And the question was, well, who's going to direct each individual what direction to move, right? There's something about collecting lots of data we needed, but then we have to have a system in place to assimilate it and make it useful and actionable.
As we put a measurement system in place, we can actually look at our gaps in knowledge and our gaps in care, feed this information back to the whole system to help their health policy and planning, and provide more focused feedback to individual facilities that lag behind, and then begin a conversation about a strategy to help them improve their pain care. Research demonstrates that this approach, monitoring, feedback, and education, which is termed academic detailing collectively, is effective in changing clinical practice with improved clinical outcomes.
The ultimate goal of the stepped care model is to decrease healthcare reliance by assisting the patients to adopt self-care methods early on, which will increase their function and, whenever possible, decrease pain. Then, as needed, thoughtfully work with the team to selectively add indicated treatments in a cost-effective, measurement-based, goal-oriented pain management plan.
The message I have for patients, is really about taking an active role in your pain management, looking at what works for you, explaining and communicating, articulating and ensuring that, if you have an idea or an option, you discuss it with them as an opportunity to try.
Understanding and implementing the stepped care model of pain management is critically important to achieving our goal of delivering quality pain care in our health system.